We're going to go ahead and move to the next talk.
Thank you, Bashir. I'm going to move to the next call. Thank you.
Okay, thank you very much. I think I don't know if you will be available later on, but we will move on and have the question answer later on. So the next talk is going to be, it's again very interesting question with so much data coming on, including ischemia, courage, and other things, and appropriateness and everything. I think it's always an important question. When we have patients with stable angina, should we treat with medications or should we cath them or not? So to answer this question today, we have requested Dr. Hany Ragy, who is a very well-known cardiologist from Egypt. He's working at one of the largest public sector cardiology hospitals in Egypt and very well experienced. So he's going to give us the answer about stable angina patients to cath or not to cath. Dr. Hany Ragy.
Thank you so much, Dr. Bashir Hani. Thank you for the invitation. I'm thrilled and honored to be in Pakistan live, and I thank the organizers. I'm so happy to see many friends here, and greetings to Dr. Latif and to Lisbeth from Sky, and I thank Sky for including me. We have known for some time that medical treatment, chronic stable patients with coronary artery disease do very well on medical treatment, way before the ischemia trial, from the days of the Courage trial, that OMT is equal to PCI plus OMT. And then came the ischemia trial, which has shown us that in patients with moderate to severe ischemia, medical therapy was not inferior to invasive treatment. And it had, for many people, it seemed like a surprise. For me, this was like a standard practice. For many years, even before ischemia.
Dr. Ragy, sorry to interrupt, but are you going to share your slides or you want us to play the...
I want you to share. I am screen sharing.
No, we are not getting it yet. Can you screen share again?
Let me try again.
Yes, please.
Oh, sorry. Let me try again.
That's okay.
Hang on.
Yes, we can see it now.
You can see. Oh, sorry. I just stopped sharing.
Yeah, stop sharing.
I'll share again. Yeah, I'll share again. Okay. Can you see it now?
Just a second. I think it's doing it.
Hang on.
Yeah, we can see it now. Yes, we can see it now. Thank you.
Okay. Yeah. So this was my first slide. This is my second slide, saying that the Courage trial showed that medical treatment was equal to PCI. This is the ischemia trial, which you all know. And this is an old article by Rossini and Tarantini and their colleagues, which was asking, should we cath or not cath? And when is best to cath? And that those were the remaining questions. It's important to remember that all the trials, including Courage and ischemia, which have proven that revascularization does not improve outcomes in stable ischemic heart disease, have actually based the inclusion criteria on a cath, on knowing the anatomy. Because those trials first excluded patients with severe life-threatening anatomy, like left main stenosis and other exclusion criteria based on the anatomy, and then they enrolled patients. So knowing the anatomy, in most cases, is mandatory. And indeed, if this is the ischemia protocol, as you see, every patient had a blinded CT angio, and especially to exclude patients with left main disease. Well, look. And this is reflected in the guidelines. How? In the guidelines, class 1, that patients with stable ischemic heart disease and multivessel disease appropriate for bypass with severe left ventricular dysfunction, bypass is class 1. And, class 2A is patients who have an ejection fraction of up to 50, who have multivessel disease and are suitable for bypass, including a mammary graft. And again, this is a good recommendation for bypass. So how would you know these patients if you did not image? You would miss them. So obviously, by default, imaging is important in stable ischemic heart disease. Again, in patients with left main, it improves survival, both by PCI and BACS. But however, cath and angio should not be a bridge to non-indicated PCI, especially ad hoc. And wherever we practice, we have seen this. We've seen patients getting taken to the cath lab and getting an ad hoc PCI in a gray indication, and very stable, based on severity of stenosis in a non-death causing segment, like a severe proximal right coronary artery. It's interesting that PCI is actually to improve survival in patients with severe three-vessel disease, even with proximal LAD, the benefit is uncertain. So the guidelines is warning us. It's class 2B. So to take stable patients and angio them and do a PCI, we're not following the guidelines. In patients with stable ischemic heart disease, normal left ventricular ejection fraction, and significant, that includes some severe, stenosis in the proximal LAD, the usefulness of coronary vascularization in general to improve survival is uncertain. Those patients, should be really triaged. They should not be done ad hoc, and they should be discussed with a heart team. And if they're asymptomatic, obviously, if they're symptomatic, it's another story. So the role of coronary CT has become very strong, and it's mentioned in the guidelines to define anatomy in patients with life-threatening anatomy. And there are some advantages. It's not invasive. It may actually even pose less chance of contrast-induced nephropathy. And we just heard a beautiful presentation on contrast-induced nephropathy. And there's been a beautiful paper, which I'd like to refer you to, on the new role of cardiac imaging and CT following the ischemia trial. So who shouldn't be cath at all, where you don't even need to know the anatomy? Let me give you a few examples. Patients who are not eligible for revascularization, such as terminal malignancy, a terminal bronchogenic carcinoma in a stable patient. Again, let me repeat, I'm talking about stable patients with probably not very many symptoms. Patients who may be harmed by angiography, such as stage 3 to 4 CKD, and again, we just saw a presentation on CKD and contrast. Patients who prefer not to have angiography should not be pushed into it. Patients who refuse and consent, obviously. And patients with known mild ischemia on previous testing, whether physiologic or anatomic testing. And question mark on very elderly patients, again, who are stable and relatively asymptomatic. It is important to know that there are many statements, including SCI statements, on the appropriate use criteria and how we should triage patients by putting a pretest probability and integrate this pretest probability before we decide we're going to cath or not into a real-world clinical practice. And this is an example of a patient where you can see the inappropriate is in red, the appropriate is in green, and the unknown or intermediate is in yellow. So you should triage your patients. Don't take every single patient automatically to look at an angio, to look at their angiobianatomy. Has this been studied? Yes. And I actually changed this presentation. In a paper from me on the health economic consequences of optimal versus observed guideline adherence, versus observed guide adherence in patients with suspected obstructive coronary artery disease in Germany. Germany has the highest rate of invasive coronary angiography, even though the German guidelines, and there has been a very good registry there, actually recommend triaging patients, recommend putting a pretest probability before cathing them. But German cardiologists just cath everybody. We know that, and they are some of the finest in the world. So this was studied, and patients with stable coronary artery disease in Germany were in a computer model, were divided into either complete guideline adherence, so you don't get the angio if your pretest probability is low and your risk is high, or you get treated the way Germans get treated. You just go and get an angio. And what happens? Guess what? If you depend on the pretest probability before you start doing invasive angios, your MACE is reduced, including death, in a statistically significant way. And of course, your cost is reduced. Interestingly, the reduction of cost wasn't very depending on, if the pretest probability was very low, the reduction in cost is really, really significant. But if the high pretest probability, then the reduction of cost is quite minimal because most of those patients are going to end up getting a Cath. So in conclusion, the majority of stable ischemic heart disease patients should have their anatomy defined. It should either be an invasive angio if you don't have CT, or if the pretest probability of needing PCI is high. And there should be appropriately fused criteria used on case-to-case basis on all patients. Those are stable patients. There's no emergency. There are a few scenarios in which imaging may not be needed or may not be necessary. You may not, like I pointed out, patients who are asymptomatic and have a terminal malignancy and who have a stable ischemic heart disease certainly don't need to be taken to the cath lab. I recently saw a patient with bronchogenic carcinoma and less than 1 year to live, who was extremely stable, who was taken to a cath lab and had 3 stents put in. The patient was almost asymptomatic except for the dyspnea caused by the cancer before. And that is a practice we want to stop. Casters, invasive catheterization, has been wrongly used to perform ad hoc PCI worldwide in many subsets of patients, including very stable patients or even asymptomatic severe proximal LAD stenosis patients. This is not recommended by guidelines. It is important to say that I'm not recommending not doing PCI for severe proximal LAD stenosis. I'm just recommending that those patients are tested for ischemia, are discussed in a heart team meeting to see if the lima is better or not. They shouldn't be taken the way we take a primary PCI patient, where we have to revascularize. Theoretically, protecting such patients from over-eager operators may be achieved by CT angio. And then, after an angio, a heart team can be done. And we now have this new published data from Germany, which was published in March this year, just last month, which have shown this careful approach to using diagnostic angiography in stable patients reduces both MACE and cost by not performing invasive angio in low-risk patients. Thank you very much, and I'll be very happy to take any questions. And congratulations on an amazing meeting so far.
Thank you so much. Great talk, and I think excellent review. And I'm sure that we have a better idea of when to cath and when not to cath now. So we'll have the question answer session after next couple of talks. So we're going to go ahead and move on. If you can stay for a few minutes, that will be great. Next 3 talks are going to be very interesting and I think very pertinent to all of us as cardiologists, physicians, or even interventional cardiologists, especially because when we are busy in our workplace, we forget about rest of the things. So I think in next 3 talks are going to really help us how we can manage our work and life balance, and how we can keep our morals high and keep working as we are. So Dr. Faisal Latif is going to talk about maintaining morale and preventing burnout. Dr. Latif, please.